well begun is only half done. So the rest of it follows. The post-operative course following PCR differs from routine cases. And as Dr. Venkatesh already pointed out, it requires a bit more and a more prolonged course of corticosteroids treatment topically, maybe even systemically for a short duration, needs non-steroidal anti-inflammatory drugs, and also more of antibiotics, prophylactic antibiotics in order to prevent infection. Furthermore, the post-operative management needs to be tailored according to the complications which may arise later on. And these post-operative course of events are influenced by the following interdependent factors: presence of vitreous in the anterior chamber, increased intraocular pressure, increased inflammation, and retained lens material. So as we keep looking at these post-operative complications, you will find all of these, one of these or many of these, as a recurring theme. The early post-operative complications you are likely to come across are corneal edema, residual cortex, wound dehiscence or shallow AC, decentration or dislocation of the IOL, uveitis, glaucoma, and increased incidence of post-operative endophthalmitis early. So here you can see that the final picture is not so pleasing, and you have epithelial edema or stromal edema, also known as striate keratopathy. The causes for this edema is usually endothelial injury causing failure of the endothelial pump and a failure to maintain transparency, or increased intraocular pressure, or both. And the endothelial injury itself may be due to traumatic surgery when you're having a prolonged surgery or a traumatic removal of the remaining nuclear bits or nuclear piece, or a toxic injury due to inflammation or prolonged uveitis. The increased IOP can be due to various reasons like retained viscoelastics, retained lens material in the AC or within the vitreous cavity, vitreous in the anterior chamber, prolonged surgery, and inflammation. The management of corneal edema is by IOP lowering medications like topical beta blockers like temolol, and systemic like acetazolamide, and sometimes may also require intravenous mannitol or oral glycerol. Hypertonic saline, that is sodium chloride 5% or 6%, may help to draw fluid out of the corneal stroma till the endothelial pump resumes functioning. Control of inflammation is required, and the dosage of steroids would have to be increased. In the case of residual cortex, you have to determine whether it is residual lens material, that is nucleus, epinucleus, or cortex, in the vitreous or in the anterior chamber. In the vitreous, it is likely to cause uveitis and glaucoma and corneal edema, and if nothing else, it may disintegrate and cause floaters to the patient. This needs to be evaluated by a posterior segment surgeon, and interventions may be necessary to remove these. Residual cortex within the capsular bag in very small amounts may be innocuous. However, if cortex is more than 3 clock hours or fluffy, it may require resurgery because it may hinder vision by dropping into the pupillary area or into the vitreous and cause the same complications as before. So this can cause uveitis or glaucoma, which may need to be treated. You can see here that there's a huge amount of cortex remaining and also a little bit into the vitreous. Wound dehiscence would usually be due to vitreous incarceration of the wound leading to a wound leak. This needs resurgery to reform the chamber and make the wound watertight, and also to clear the vitreous from the wound in order to avoid late complications. Weak wounds lead to delayed wound healing and therefore even to late stabilization of refraction. Uveitis would be due to retained viscoelastics, prolonged surgery, and retained lens material. Glaucoma, the narrow angle could be due to shallow AC and a peripheral anterior synechia leading to a pupillary block by the lens, or due to an inflammatory membrane, or retained viscoelastics, or vitreous, or inflammation. The other thing that can happen is a decentered IOL, even if carefully placed, and this can be causing visual disturbance and may need repositioning. So there's a simulation of how it looks like through a decentered IOL. There's a uniocular diplopia, and this may require treatment. Vitreous in AC could be either in the form of a strand or a knuckle, and this may require vitrectomy either through the pars plana route or through the anterior route, or YAG vitreolysis. And vitreous remaining in the anterior chamber could lead to early or late complications. Some of the late postoperative complications that we are likely to come across are cystoid macular edema, retinal detachment, postoperative endophthalmitis, glaucoma, persistent corneal edema and decompensation, decentration or dislocation of the IOLs, and epithelial fibrous ingrowth. Cystoid macular edema is the most common cause of unexpected visual loss, sometimes even after recovery after cataract surgery. And this could be either angiographic or clinical. Angiographic is reported to be having a higher percentage, around 11% on an average, or even as high as 40%. However, clinically, it is between 0.1 to 2.35%. The definitive risk factors which cause cystoid macular edema include vitreous loss, vitreous incarceration to the wound, and addition to the iris, which you can see in this case. All the three things are present here. And also it could be due to iris manipulations and inflammation. The mainstay is treating it with corticosteroids and non-steroidal anti-inflammatories which act synergistically. The preferred non-steroidal anti-inflammatory drugs are ketorolac and nepafenac. Subtenons and intravitreal corticosteroids can be used in cases refractory to topical treatment. Vitrectomy may be required to relieve the traction and Nd:YAG laser to lyse the strands. Even as such, retinal detachment occurs at a rate of 0.6 to 1.7% in the first year and continues at an overall rate of 0.7% every year. And PCR has been isolated as the single most significant factor in the development of pseudophakicardy. In patients with pseudophakicardy, the rate of PCR without vitrectomy was as high as 4% as against 1.1%, and in controls, and when vitrectomy was done, it was as high as 34.5%. The development of RD after cataract surgery is related to the increased or early occurrence of posterior vitreous detachment, and this itself happens because of loss of hyaluronic acid, increased vitreous gel mobility, and increased vitreous syneresis. Vitreous loss increases the vitreous traction due to incarceration to the wound, and it adds to the risk to retinal detachment. Therefore, there is a need to screen the retinal periphery for the retinal breaks, even in an otherwise normally a well-managed patient of PCR. 80% of breaks could be found in the superior periphery. There is a need to inform the patients to report immediately in case of symptoms like flashes of light, and symptomatic lesions need to be treated immediately. RD surgery would be required in cases with retinal detachment. PCR and vitreous loss increase the risk for development of endophthalmitis because of increased surgical time, increased instrumentation. The effect of the barrier is lost, the posterior capsule is not there. Vitreous in the wound would act as a wick, and organisms sequestered in the vitreous can lie dormant for a very long time and then cause a delayed infection if the immunity may be low. The other complications are pseudophakic bullous keratopathy, and this could be due to endothelial touch by vitreous or a decentered IOL touching the cornea. PKP or DSEC may be required. Glaucoma in the late stages could be because of vitreous in anterior chamber, inflammation, or as a response to steroids for controlling this inflammation, due to peripheral anterior synechiae, and very rarely epithelial and fibrous invasion. Epithelial fibrous invasion of the anterior chamber is a rare and blinding complication where you get to see a sheet-like invasion into the anterior chamber. Late decentration and dislocation of IOLs could also occur when inadvertently one of the IOLs is placed under the rhexis and one over the rhexis, as you can see here. It can occur after capsular bag contraction due to vitreous generation or even following trauma to these patients. IOL exchange may be required. To summarize and to reinforce, let's look at some of these studies. The short-term outcomes following PCR was studied by Fiona Chan in Singapore. A case of 155 PCRs, a rate of 1.9%. 13 were excluded due to incomplete data and 27 had ocular comorbidity. Among these cases, the visual recovery was 87%, achieving 6/12 or better between 6 weeks and 3 months. The causes for poor vision in otherwise with the eyes excluded were CME in 2 eyes, PCO in 2 eyes, endophthalmitis in 1 eye, glaucoma in 1 eye, retinal detachment in 1 eye, CME, CRO, which is hemorrhage, all in 1 eye. So you can see that all these complications which are mentioned were quite common. Sumro Onal et al. Studied 58 eyes with PCR and compared them with 159 without PCR, and this shows the odds ratio for various complications. Retinal detachment 11.7, CME 26.3, increased IOP 14.54, and decentration 32.79. So as compared with controls, the rate of complications were much higher. Also, the refraction stabilized 2 to 6 months post-operatively in eyes with PCR rather than the usual 1 month or 15 days. To conclude, a well-managed PCR gives a good post-operative outcome, but still some of these can have some of these complications. It requires a frequent follow-up of the patients and also for a prolonged duration, because retinal detachment has been seen to almost 4 to 6 years after surgery and may occur even very late. We need to carefully look for development of any new complication, and appropriate management needs to be instituted. All these ensure a good vision and a satisfied patient. Thank you.